Hey everybody, it's Dr. Letitia and welcome back to my web show, Coffee and Conversations. I am so excited to bring this guest to you today. I am a definite fan and follower of hers, and I was so excited when she agreed to do this show. I hope that you will learn so much from her as I've learned from following her. Let me introduce Dr. Madeline Sutton MD. Dr. Madeline is a board certified obstetrician and gynecologist who is also an author, speaker, and consultant. In addition, she provides expertise regarding women's health issues, public health strategies, and health equity. She's a retired veteran of the U.S. Public Health Service and is nationally recognized as a mentor for historically underrepresented early career scientists and clinicians. She's published over 150 scientific articles and one book in the areas of women's health, sexual health, and HIV STD prevention. She's also provided care and instruction internationally through mission work and clinical trainings in Haiti, South Africa, and Ghana. And as the founder and chief medical officer of drmadelinmd.com, she discusses actionable ideas and real-world strategies to help women take control of their health and have more freedom. Dr. Madeline also shares medical expertise via her Facebook Live sessions, Instagram posts, and Twitter updates. Dr. Madeline earned her Doctorate of Medicine and Masters of Public Health degrees from Columbia University College of Physicians and Surgeons and Columbia University Mailman School of Public Health, and completed her internship and residency at University of Medicine and Dentistry of New Jersey, now Rutgers University. Her upcoming book, In Control, will be published soon. Thank you so much for listening to the bio of Dr. Madeline, and please join me in welcoming her to our show, Coffee and Conversations. Hello, Dr. Madeline. How are you?
I'm great, Dr. Letitia. Thank you so much for having me.
Thank you for being a guest. I said to the listeners earlier, I am definitely a fan. I listen to your Facebook Lives. I listen to your Instagram Lives, and all of your posts have been so informative. And that really is what made me want to have you on the show. Thank you so much for what you do.
Oh, well, thank you. Thank you. You know, it's such a joy. I love working with women, love taking care of women. And, you know, I'm glad to be here. Glad to have the conversation with you with some coffee.
Exactly. You got your cup. Perfect. So let's jump right in. What made you interested in becoming an obstetrician and gynecologist? Where did your interest in women's health start?
Well, thank you for that question. You know, when I was little, so I grew up in Harlem, not far from where you guys are now. And so it was early on that I saw a Black male pediatrician in the Harlem area who, I mean, he was fantastic. He was taking care of, I think, so many children in Harlem. And he was someone that I looked up to and thought that was the first time I said, oh, okay, you know, there are doctors who look like us, you know, and something that might be something that I wanted to pursue as a career. So fast forward to I think I was in 8th grade. I had some sudden lower abdominal pain on my right side, went to the hospital, ended up having an appendectomy, met someone who was a great surgeon. This surgical resident came back the day after and showed me my appendix, and I just thought that was the coolest thing. I began to be even more serious about wanting to become a physician. But it wasn't until I was in the first part of med school that I met other Black female OBGYNs who were doing this great work in terms of women's health clinically, but also public health research and really trying to impact policy and level the playing field, so to speak, in terms of health disparities and making sure women of color were getting access to things that they needed and all of that. And that was when I more seriously decided to think about OBGYN. Before that, for many years, I had been thinking that I wanted to be a pediatrician. And
okay.
Lo and behold, I started seeing sick babies, and I was like, you know, it was heart-wrenching for me.
Yes.
So I fell in love with all aspects of OBGYN.
Okay, awesome. Thank you so much for that. Now that we are here in the month of April, and April is Sexual Assault Prevention Month, tell me what we need to know as women in terms of keeping ourselves safe, what we need to do if there is any type of assault or abuse? And do you come across any type of sexual assault in your clinical work?
Great question, Dr. Letitia. So, I think one of the main things to try to do for women is a lot of times things can happen if women are separated from a friend group or something like that. And
Yes.
so, because a lot of times things can happen on a college campus, for example, one of the big things to keep in mind or to be mindful of is, when you go in certain places, have that sister friend or a guy friend or whoever, someone who's going to keep a constant eye out for you, make sure you're okay. Even if you're not okay, that person's going to help you get home and do so in a respectful and kind way. That's one thing we can do for prevention. But on the other end, a lot of this really rests with the males who might be doing the assault. We really need to help make sure men are informed about different parameters when it comes to women, when it comes to no meaning no, or just really helping men understand that whole context of sex. We certainly understand that when people are late teens, early 20s, there's a lot of development that's still going on in terms of their brains. And I think the more that we can talk about what's clearly wrong and what's clearly okay, the more we can make sure people understand. And certainly we can't underscore enough the importance of alcohol and other substances being part of the picture a lot of times when there's an assault involved. And so really trying to scale back on some of that as well on college campuses or anywhere an assault might happen. I tend to come across assault definitely in clinical practice, more so in the emergency department. A lot of times will come through the emergency department, and it's certainly something that requires a lot of sensitivity, a lot of care, a lot of kindness with the approach. It's not about jumping straight to the clinical exam. It's about sitting down and talking with the person, seeing how they're feeling, where are they in terms of what they want to do next. And so it's an important, very important patient that we take care of, the person who has been had such sexual assault.
Thank you so much for that. I want to switch gears for a second, Dr. Madeline. So I am a mom, and I know that there are many moms that are listening. So what age do you think is a good age for a mom to take a daughter to see an OBGYN? What would you suggest?
Great question. So, there's a professional body that most of us OBGYNs are part of, American College of OBGYNs. And that just means that we've gone through some examinations and become board certified to, and that we practice at a certain standard of care.
Okay.
So most ACOG data support taking a young woman in by age 14 to at least have a conversation.
Okay.
To make sure she has, if she has any questions about anatomy or how she might be feeling or anything she might be going through puberty-wise, 14 is a good time, especially if a mom doesn't feel comfortable having that conversation on her own. 14 is a good time to take her in to see either an OBGYN, or if the pediatrician feels comfortable having that conversation, the pediatrician is certainly a good resource for that. Not every pediatrician feels comfortable, but at age 14, many times teens are still seeing pediatricians as their primary providers. But that's absolutely a fine time to bring someone in to see the OBGYN. And if a woman does decide to bring a daughter, a young lady, if it's an aunt bringing in a niece or something like that, if they do bring them into the OBGYN, it's important that they know that no pelvic exam is required at age 14. It literally is just having a conversation, answering their questions. The time when a pap smear is required is age 21.
Okay.
That's important to know. If someone is sexually active before that, we can do a pelvic exam if they have a concern or a question, but it's not required. It's not even required to start birth control.
Okay.
But, so I think it's important also that moms, aunties, our teen girls know that as well, because we don't want them to feel scared about coming in or hesitant to come in because they think someone's going to be poking around down there. That's not
exactly
part.
That's awesome. That's great. So I will definitely, I will definitely be having a conversation with you offline about bringing my 15-year-old to you. Because I'm like, I think it's time. I think it's time. So that's so good. Thank you so much for that education. And thinking about all that comes with health disparities, especially around Black women having babies. I think about some of the recent stories in the media. Serena Williams has definitely spoken out and talked about what happened with her when she had her baby. Beyonce spoke out and talked about what happened with her when she had her twins, and I just feel like it's constantly a conversation with Black women just getting low level care at times, even if they're celebrities with all the resources in the world, or just having difficulties delivering. Why is that? Can you enlighten us as to what is actually going on with us giving birth?
So, Dr. Letitia, this is something that tugs on my heart. It's tugged on my heart for a long time. And the data show in this country that when it comes to maternal mortality specifically, certainly Black and brown women are faring worse than non-Hispanic white women. And so the latest estimates show that Black women are 2 to 3 times, in some places in the country, 4 times more likely to die either during childbirth or in the year following childbirth compared to a white woman. The rates are also higher for Native American women.
Wait a minute, Dr. Madeline, you got to run that back. Wait a minute. You got to give us that statistic one more time because that is staggering.
It is. It's unacceptable. And when you look at the trend, unfortunately, even as we get better with technology and everything, and for this country, in the United States of America, maternal mortality has actually been creeping up for the last couple of decades. And when you look at other countries that are as industrialized and advanced as we are doing the worst compared to those other countries. And so specifically when you look at women, and these data were published by CDC a couple of years ago, it's unfortunately, we have about 700 maternal deaths in this country every year. And when you look at the numbers, Black women are about 2 to 3 times, in some parts of the country, 4 times more likely to die giving birth or in the time right after giving birth compared to white women in this country. The rates are also high for Native American women and for Hispanic women in some parts of the country. And so it's absolutely unacceptable. The biggest thing that's going on, and it's a timely discussion because in this country, we're having this bigger discussion about racism, right?
Yes, correct.
The fact that, something is not happening when people see brown skin that should be happening in a different way. And so, when we look at the data, there are data that show sometimes there are issues with access for women of color. If you aren't able to access healthcare early enough, then that's a challenge. When you look at the maternal mortality numbers, for example, in the South, in spaces where health access was a challenge because maybe there wasn't Medicaid expansion or other things that go on, you see higher numbers for us in that part of the country. But when you control for all of that, even when you look at Black women who are college educated, the outcomes for college educated Black women are still worse compared to a high school educated white woman. And they've done many studies now, and one of the things that's consistent across all of those studies is the racism factor. It's not, Black and brown women are doing anything worse, so we're not causing ourselves harm. It's not that. There's a racism factor in that providers are not hearing Black and brown women the same. So,
Yes.
You brought up Serena Williams and other, prominent people who have had issues when it came to childbirth, and that's absolutely the case. If you look at the case that happened with Kiera Johnson, I don't know if you are familiar with that case.
Yes.
One
Yes.
a few years ago, it was a similar thing where she was post-op from a C-section. She had bright red blood in her catheter mixed with her urine, which is a clear sign that there's active bleeding going on somewhere. And even though her husband was trying to get the attention of the care team, it was, I think he described, over 6 hours or more before something was done. And unfortunately, it was so late by the time they took her back that she died. Now the question is, and this, I say this, and many of my colleagues say this as well, if she were not a Black woman, if she were a white woman, it would not have taken that long probably to get her back into care.
I agree.
And she'd be alive today. So we absolutely have to get to the racism part of this. There are some hospitals in California and other places are starting to follow suit, where what they're trying to do is standardize protocols. And so, there's a standard of care that physicians and nurse teams and everyone should have when they're taking care of patients. And sometimes that standard of care will fluctuate if someone has internal biases. Okay.
Mm-hmm.
And so
Absolutely.
when you standardize these protocols, what you're trying to do is say, remove your biases, treat everyone like we have written here. If you see this, then do this. It does that way. When
Doesn't
you
matter. Doesn't matter how they show up in the world.
exactly, exactly, you remove that subjective factor, and you can ultimately get better outcomes for us and our sisters. And we just have to do better. It's absolutely tied to racism.
Absolutely. And this is why I love having people like you on the show, because I need people to see other people that look like them, that are doing the work, because I think that just as you were inspired as a young person and I was inspired as a young person, people need to see us, right? We need to be as visible as possible so that the next generations can come up and say, you know what, I want to do what Dr. Letitia is doing. I want to do what Dr. Madeline is doing, because our lives are at stake. When you hear the whole Black Lives Matter rally cry, it's not just about police brutality. It's also about our access to education, our access to clean food and water, and most importantly, in my opinion, our access to quality healthcare.
Absolutely, absolutely, Dr. Letitia. You hit the nail right on the head. All of those things are part of Black Lives Matter, and we are suffering at the hands of racism and old ideas and people who aren't willing to change in so many areas in this country. We have to have an overall concerted effort to shift this, because it's gone on for far too long, and literally we are dying. We are absolutely dying.
What would you advise, Dr. Madeline? Because I think that another phenomenon, so you're in the medical side, but from the mental health perspective, just in speaking to my own clients, so many times I think that patients and our community members are nervous when it comes down to questioning their doctor or getting a second opinion, right? Like, I think that white coat syndrome is real. So many people don't go against what the medical advice they're given is. What suggestions do you have if patients feel uncomfortable speaking to their doctors? What should they do? How should they go about trying to bridge that gap a bit?
That is such a great question, and it's so hard because everyone is in a different space when it comes to talking with a provider and getting what they need. So a couple of things. I think that it's always good to have an advocate. If even if if you're not pregnant, if you're going in and you're seeing your provider, see if a family member can go with you. I know during the time of COVID, people pretty much had to go on their own.
Sure.
But we all have these phones these days. Call somebody, have
yes,
somebody.
We do.
Put somebody on speakerphone and say,
Mm-hmm.
"Hey, doc, are you okay? I have my sister, my husband, my partner. I have my adult child, and they want to know more about what's going on with me. Is it okay if they hear this?" Having an advocate can be huge, because they might help if you forget something that you wanted to ask. They might ask a question in a little bit more of a tougher way, or get to more of the nitty gritty of what needs to be gotten to, especially if the patient is kind of shy or doesn't feel comfortable. That's definitely one thing I would suggest. Have an advocate, even if they're just present on your phone. For pregnant women specifically, I always say to people that I meet, find you a doctor that you can just kick it with. If it's not the first one, keep looking. But not everyone feels comfortable. Not everyone's insurance will allow them to go and explore. So for pregnant women specifically, doulas are a great asset to have as part of your OB care team. So a lot of times, and more so as we get back from COVID, doulas are, they're not like medically trained necessarily, but they will use, a lot of times have certification, but they are, in addition to the OB physician, in addition to the midwife, the doula is great with providing support and advocacy just for that pregnant woman. She doesn't care about the doctor's attitude, or anyone trying to give that patient a hard time. A doula is, will be ride or die for that patient. And so I think that's another great thing to keep in mind. A great option for women who might be pregnant or postpartum is having a doula as an advocate to help be a part of those clinical conversations. And for people who are non-pregnant and just going through their routine medical processes, having an advocate, even if they're on the phone, just someone to help them go through questions that they have and express concerns. And if they fully aren't happy, I absolutely say go find another doctor. There are plenty of doctors out there, except in some rural areas where they're kind of sparse. There are usually options out there, and I encourage women to find the person that kind of clicks with them and will sit and listen and talk with them.
You are the first OBGYN that I have ever heard in my 4 decades of life list a midwife or a doula, right? So even that's so like, right? I think that you have, in our country, there is a huge divide between like Western medicine and Eastern principles and philosophies for medicine. So it's so important to hear that all can work together for the benefit and betterment of the patients.
Absolutely. Listen, Dr. Letitia, this maternal mortality thing, it's an all
It's
hands on
real.
deck situation.
Yes.
It is all hands on deck. And so when I'm talking to people, I'm not afraid to work with a midwife. I embrace working with a doula because at the end of the day, we are all about that patient and saving that patient's life and making sure that she has a positive birth and pregnancy experience. And so, I think more of us are beginning to shift mindsets, but you're right. There are some old school obstetricians. They don't want to talk about midwives or do.
No, not at all.
Right. Because I think, back in the day, it used to be seen as adversarial, but we're not.
Yes.
Adversaries, especially in a country where we've been seeing an increase in maternal mortality. We can't look at each other as adversaries. We have to look at each other as, okay, I got this part. Which part do you have? Okay.
That's right. We're allies. That's right.
Exactly. For the good of the patient. We're allies for the good of the patient.
One thing that I wanted to bring you to before we close, Dr. Madeline, you mentioned it briefly. You talked about postpartum depression, right? So postpartum patients. I have treated in my 20 plus year career many women who have really struggled a lot with postpartum depression. When you see this in a patient, what is typically, done? What is done from the OBGYN perspective in order to get help or link that person to mental health care?
Great question, Dr. Letitia. So one of the things we do routinely in postpartum care, and one of the things specifically that has shifted, I would say, over the last 2 years, is we screen routinely for depression. We use a standard scale with all women when they come back for their postpartum visit. Now, if you recall, I think you said your daughter is 15. So
yes,
when you and I had children, it was just that 1 6-week postpartum visit.
That was it.
Yes. So now we see patients back at 2 weeks postpartum, 4 weeks postpartum, and because we're trying to detect earlier and screen earlier if there are any issues that pop up, whether it's due to depression, whether it's due to an elevated blood pressure, or anything that could put a woman on our radar as maybe needing some more help and support. And so we do that screening, depending on what the conversation is like when I'm talking with her or her family member and how she does on the screening test. I will a lot of times loop in some mental health support. So, someone who does therapy like yourself. What I find here in Atlanta, and it's getting a lot better, and I'm sure you can speak to this too, Dr. Letitia. It's really important that we have culturally aligned mental health providers. So I don't know.
Yes.
So we need more Black and Brown mental health providers because
yes,
there are so many things that go on culturally for different women of color that having a mental health provider, I'm more successful when I have a patient in my office if I have a mental health provider that I can link them to that they feel will understand what's going on with them culturally.
Absolutely.
And when I don't have someone that I can link them to that is aligned culturally, they're more likely to not go. They're more likely to still be feeling down when I talk with them. And in those situations, I have to lean more toward using medication, which is fine. Having to add on some Zoloft or something like that is fine. Mm-hmm. But I'm also of the belief that there are things that you have to talk through.
Absolutely.
You can't just give medicine and I send you home and you'll be fine. You have to talk through some of this stuff. Dr. Letitia, did you see the Oprah interview with Megan?
I did.
I was struck that the term postpartum depression was not used at all in that
That's
whole
right.
conversation.
That's right. That's
It
right.
was it was so clear. She was pregnant, then she was postpartum, and now she's pregnant again. I was like, she needs some postpartum.
She needs some treatment. Yep.
Yes, yes, absolutely.
But I feel like there's still a lot of stigma, right, around postpartum treatment. There's still stigma in the mental health arena. I think that things are better now than they were 20 years ago when I started, but we still have a long way to go. I mean, less than 5% of people, are Black psychologists in the United States. Less than 5%, so we definitely need more, diversity. We definitely need more inclusion. But I just feel like when it comes to postpartum, people don't want to talk about it. It's almost like, be happy the baby's here. Be happy, you delivered successfully. So many women don't really know where to go for help or how to get help. Or like you said, it's like, let me just get a pill, I'll be okay. And I really think that it's important that we bridge the gap. Medication absolutely has its place. I tell my clients all the time, there is certainly a place for that in your life. However, you still need talk therapy. There still is a need to be able to rationalize some of the things that you're feeling and have that mirror, right? Our job is to be that mirror for clients. So I agree with you wholeheartedly on that. We definitely need to do that.
Absolutely, absolutely. We definitely need more of that and need more providers of color. I will say this: social media and telehealth has helped.
Yes.
I think that there are more platforms, therapy for Black girls, and
yes,
and I think there's therapy for Black men that I've seen online. These
yes,
are great because then people can go on and see, okay. And sometimes I go on and say, okay, well, where's someone else in this area? I'm looking for someone. Maybe their office has closed due to COVID, and where else can I send someone? So, we have these social media platforms, and also a platform like yours where people get to look and see and hear Dr. Letitia. Let me reach out to Dr. Letitia and see, if she's taking clients or something like that.
yes.
So I think we're doing better, but we absolutely have a long way to go. And then, you mentioned the stigma. There's also stigma culturally. A lot of our families aren't yet at the place. Oh, take it to God, or
that's right. Just pray about it. Go pray about it.
Absolutely. Nothing wrong with prayer.
There's nothing wrong with prayer. That's fine.
Prayer and to talk to a therapist,
I have a t-shirt that says it's okay to have Jesus and a therapist. Yes. I have a t-shirt that says that. Absolutely. There's a place for our spiritual beliefs. There's a place for us to express ourselves in that way. But there are also times where we need to go to our physician, right? You got to go see Dr. Madeline. Or if you're dealing with something emotionally or with your mental health, you got to come to a Dr. Letitia. You have to do it if you want to be well, right? I think that it's time for us as a community to look at health and wellness holistically. It's about mind, body, spirit, soul, everything being aligned and being in sync. We can't get around that.
Absolutely.
Thank you. Yes, please.
So I want to say this because you brought up the question about teens and being brought in by their moms. So yes. Also important for the moms who might be listening or the teens who are listening to know that because sometimes moms are shocked when they come into my office or they call. Teens in most states in this country can go and be seen by a provider without their parent.
Without consent. Yes, that's right.
A lot of times the teen will end up telling a parent because the insurance thing might come in the mail. But
Sure.
Important for teens to know that they can go confidentially and see a provider, especially if they have some concerns and they just want to get checked out, or if they're already having consensual sex and they want to get birth control or something like that. So I just want to
thank you so much for that. That's important.
No problem.
That's important. And I know, parents have their thoughts about that, but I think that overall it's about health and safety, right? It's about lessening negative outcomes, right? We want to address HIV and AIDS. We want to address STDs and STIs. We don't want, the next generation to have to deal with those issues. And so we have to normalize access, even parents, if that access means you're not there, right? Even if you're not included, right? It's about wellness. And so we have to encourage that.
Exactly. And most times teens will loop their parents in. They might
Sure.
want a provider to have the conversation.
Absolutely. Dr. Madeline, this has been amazing. Thank you so, so much. Please tell people how they can get in touch with you and how they can Instagram stalk you like I did.
Well, thank you so much, Dr. Letitia. So, I'm Dr. Madeline. I'm actually on Instagram, Facebook Live, Twitter, and I'm also on Clubhouse as Dr. Madeline MD. So that's DrMadeline MD. And please follow me there. I love giving tips and trying to update when there's information that women could benefit from. I have a book coming out in a few weeks called In Control, and it's going to be everything you might need to know about worry-free and joyful sex. I like to talk
Oh,
about worry-free and joyful sex because I think truly worry-free and joyful sex means having birth control if you have an opposite sex partner, and you know, condoms, other things to kind of make sure that a woman has the most freedom and control that she desires, you know, as part of her existence and her space. So that's my motto on my social media platforms, and I look forward to seeing y'all there. And thank you so much for having me, Dr. Letitia.
absolutely. I have to have you back. I have to get the book. I definitely want to ensure that I get the book. I will certainly be promoting it because again, we have to normalize that sex is supposed to be pleasurable, enjoyable, safe,
Exactly.
right? For women, right? So I will absolutely have you back to talk about the book when I am done reading it because that is something else that so many of my clients need more information about. They need to be educated and they need to feel comfortable about having conversations about enjoying sex. So I thank you so much, Dr. Madeline. I can't wait to have you back.
Thank you. Thank you. I can't wait to come back. Thank you.
Thank you so much.
Okay. Take care.
Bye-bye.
Bye bye.